Hi, good night, everyone. I'm Dr. Ramsamuj. I'll be presenting a series of talks on vascular anatomy and cerebrovascular diseases from tonight. So basically, this topic encompasses a lot. The topics, we tweak it a little bit, but the topics are basically vascular anatomy of the brain, and then touching on subarachnoid hemorrhages and aneurysms, vascular disorders, and then ultimately stroke and occlusive cerebrovascular diseases. So tonight to kick off, we'll be doing vascular anatomy of the brain, specifically anterior circulation. And then as of next week, we'd be doing posterior circulation and venous drainage. So we know that the brain is about 2% of the total body mass. It uses nearly 50% of human body's glucose, making it the most energy intensive organ of the human body. It receives about 17% of cardiac output and uses up to 20% of the body's oxygen. So then it follows naturally that the brain ought to be one of the most perfused organs in the body. Two major sources of arterial blood provide this perfusion, like I would have mentioned, the anterior and the posterior circulation. So the anterior circulation originates in the internal carotid arteries, and the posterior, the vertebrobasilar circulation, originates in the vertebral arteries. And we're going to follow these exactly from the aorta come up. Now, once these arteries enter the cranium, they branch exuberantly, eventually supplying blood to all the deep and superficial regions of the brain. Naturally, any perturbation of any portion of this, whether it's intracranially, whether it's extracranially, promotes the development of cerebrovascular disorders. So this is a basic picture, we've seen it, of the cerebral arterial network. And we see the carotid arteries, we see the vertebral arteries, ultimately the anterior cerebral and the middle cerebral coming from your carotids, posterior cerebral, and we'll get into the rest of it, forming what we knew since med school of the circle of Willis. So in that sense, this cerebral arterial network of vessels, it's unique in its anatomy. The flow dynamics is inextricably intertwined in terms of other fluids, venous blood, cerebrospinal fluids, as well as interstitial fluid. So what we need to understand at this baseline right now is that the vascular supply of the intracranial CNS components really is from both branches and anastomoses of the carotids, as well as the vertebral arteries, which we already know. This is just a backdrop to bear in mind when we're talking about vascular anatomy as it pertains to the vascular territories, because knowledge of the arterial vascular territories is important as it enables us to recognize infarctions in the arterial territories. So we know that the cerebral hemispheres vascularized by the anterior cerebral, middle cerebral, posterior cerebral, as well as the anterior choroidal arteries. And we see them well displayed in terms of blue, purple, and green. So I just want you to bear that in mind, because when we get into, infarctions and strokes and aneurysms and deficits that patient would present with, this is where this becomes equally important. So cerebral circulation, already established that we're talking about our carotids and the vertebrals. So the main arteries of the head and neck are the right and left common carotid arteries, each of which then divides into an external carotid and an internal carotid. We need to remember that the common carotid arteries differ in their origins, meaning on the right side, as we can see in the picture, the brachiocephalic trunk bifurcates into the right common carotid and the right subclavian, and on the left it arises directly from the aortic arch. Further to that, then the subclavian artery it's usually the main supply of the upper limb, it's called the upper limbs artery, but it also supplies the thoracic wall, head, neck, and brain through its branches. So let's get cracking into the common carotid. So already establishing where it is, each artery runs upwards from the sternoclavicular joint to the upper border of the lamina thyroid cartilage, where it then terminates into internal and external. And usually the lamina of the thyroid cartilage lies about between the third and the fourth cervical vertebrae. And then each common carotid artery again lies in front of the transverse processes of the lower four cervical vertebrae under the cover of the anterior border of the sternocleidoid muscle. So following this, let's just remember that the external carotid artery supplies, as the name suggests, structures external to the head and the greater part of the neck. And the internal carotid artery supplies structures within the cranial cavity and the orbit. Now, as we've already said, the brain parenchyma is supplied by two internal carotid arteries and two vertebral arteries. So the ICA, or the internal carotid artery, it enters the skull base through the carotid canal, located in the petrous portion of the temporal lobe. It then passes through the dura mater, the level of the cavernous sinus, bifurcates within the subarachnoid space, and then ends up as the middle cerebral and anterior cerebral arteries. Why is it so important? Carries up to 80% of the total blood to the brain. And then the vertebral arteries, which we mentioned before, enter the vertebral foramina, the level of C6, the exit out of the exit out of C1 foramina, loop around the posterior arch of the atlas as they enter the foramen magna on the ventral surface of the brainstem to form the basilar artery. And we can see that here because it comes back to what we're saying, your subclavian, your external carotid, and your internal carotid. And here, with the vertebral arteries, they come up, they run along, and then they join the basilar artery to form the basilar artery, sorry. And then it terminates into the posterior cerebral artery. So together, this forms what we know as the circle of Willis, the anterior and the posterior circulation. So as much as we're going to be focused heavily on the ICA, it's important to mention the external carotid artery, which extends again, as we would have mentioned, from the upper border of the lamina of the thyroid to a point just behind the neck of the mandible, terminates into the substance of the parotid gland, where it then divides into its terminal branches, the superficial, temporal, and the maxillary. Generally, that bifurcation right here occurs about 1 centimeter superior to the thyroid cartilage. So generally, the 8 branches: superior thyroid artery, lingual, ascending pharyngeal, facial, occipital, posterior auricular, and your posterior auricular and your occipital are your posterior branches. And like I said, the terminal branches are the superficial, temporal, and your maxillary artery. This table has been included for the sake of completion to remind us of the branches of the external carotid, as well as vascular supply and the different anastomoses. Importantly, I would shed a little light on the maxillary artery because it gives off the middle meningeal artery, and that becomes particularly important, especially in our field as we talk about epidural hematomas, etc. Now, this picture has been included for the sake of textbook and real life. We've seen it looking differently, right? So this is a cadaver that would be showing you the common carotid, the external carotid, and the internal carotid. So important to remember in terms of the anatomical structures, the ICA initially, which we see here, lies posterior lateral to the ECA, and then becomes medial to the ECA to enter the carotid canal, just anterior medial to the internal jugular vein. And of course, this becomes even more important when we remember the carotid sheath, which is formed from the 3 layers of the deep cervical fascia. Of course, we know our carotid sheath has a common carotid artery, including internal carotid artery, the internal jugular vein, and the vagus nerve, right? And the clinical correlate to this would be, when we do our ACDF procedures, we have to identify our carotid sheath and our esophagus in particular. So this is why this becomes particularly important to be, to have on like the back of our hand. So I did mention that we would talk about the maxillary artery a little bit as one of the branches of the ECA, and really it's a clinically important structure when treating neurological diseases using surgeries. It is embedded in a groove of the skull, and trauma or iatrogenic factors can result in pseudoaneurysms or arteriovenous fistulas with the middle meningeal artery. So really, the maxillary artery gives off approximately 14 different branches, but the relevant ones are the middle meningeal artery, which I already said tends to be highly susceptible to bleeding, especially after choroidal trauma, the accessory meningeal artery, and the anterior and posterior deep temporal arteries. So the middle meningeal artery is one of the largest branches of the external carotid artery, and it is the most important dural artery because it supplies more than 2/3 of the cranial dura. More importantly, because it is so adherent to the bony walls of the skull, naturally in trauma and any sort of injury to the bony walls of the skull can result in injury to the middle meningeal artery. And we then understand why in up to 85% of cases, injury to middle meningeal artery will result in an epidural hematoma. I included this for the sake of I thought it was very useful knowledge, and just, as we're discussing middle meningeal artery in terms of other clinical implications, of this, in the form of chronic subdural hematomas, meningeal tumors, and dural AVFs. Now, we know with chronic chronic subdural hematomas, we tend to have membranes forming because of the inflammatory response caused by residual blood. Now, these membranes are also stimulated by angiogenic factors that stimulate neoangiogenesis, which results in formation of fragile microcapillaries, leading to a higher recurrent risk of bleeding. So after that, what has been happening is that investigators and researchers have gone on to check this out and say, well, is there something that we can do? Because remember, we already said that the middle meningeal artery is a principal blood supply of the bleeding membranes. So occluding it, in essence, allows the collection to be reabsorbed. So in particular, in a study, Link et al., they proposed that for the management of recurrent chronic subdural hematomas, you can do endovascular MMA embolization. And what they found in their paper published in Open Neurosurgery in 2018 is that the recurrence rate was similar to surgical evacuation, but you had a less invasive procedure. Now, as it pertains to meningiomas, we know they're the most common benign intracranial tumors, most likely skull vault or the skull base. And again, because the MMA is a major dural artery, as I would have pointed out earlier, most cranial meningiomas receive its supply. We know for first-line treatment for symptomatic meningiomas, it's operative, but preoperative MMA embolization has a role to reduce the blood supply of the meningioma, to perhaps limit blood loss during resection, especially based on the Richter classification, where the 4 types are type 1 being exclusively supplied by the ECA, type 2 you have a mixed picture, predominantly the ECA, type 3 predominantly ICA, and type 4 exclusively ICA. So in another study published by Dubai et al. In 2015, they found that MMA embolization should be reserved for meningiomas type 1 or 2 on the Richter classification. And then as it pertains to dural AVFs, transarterial embolization through MMA has been described as a successful option for dural AVF treatment. And in fact, if you have a very good MMA supply, it tends to be one of the best predictors for successful embolization. So that's just a clinical caveat and correlate with middle meningeal artery. So continuing on to anterior cerebral circulation, which is the basis of the talk today, we know it's composed of branches of the ICA, but particularly there are several branches in that you have the ACA, the middle cerebral artery, and the anterior choroidal artery are highly prominent and pathophysiologically significant. Now, the function of the anterior division of the cerebral circulation is to supply blood to a large percentage of the forebrain, frontal lobe, temporal lobe, and parietal lobes, as well as to the diencephalon and the internal capsule. It should be noted that the contribution of the anterior circulation to total cerebral blood flow has been measured in as high as 72% on an MRI. So just so that we're all clear, we all know the circle of Willis, but this is the part of the circle we're going to talk about tonight. The internal carotid, middle, anterior cerebral branches, anterior communicating, ophthalmic, and anterior choroidal artery. So, big bad boy, internal carotid artery. There's been several classifications, and historically, one of the first ones was Fisher classification, which is really no longer used. It was first devised in 1938, where they designated intracranial ICA from C1 to C5, as we can see here. But importantly, what they would have done was to do it against the direction of blood flow. And their aim then was to help to localize skull-based lesions via their mass effect on different ICA segments. And it was particularly not designed to describe ICA aneurysms. For them, it was simple. It was doing the job. But for us, we've moved on since then, and we'll continue that story. So about 30 years later, Gibo, Lenke, and Roton, based on incredible supraclinoid ICA dissections, which actually became a landmark for vascular neurosurgery, classified their findings according to the Gibo system. And they then numbered it from C1 to C4. And they would have done cervical, petrous, cavernous, and supraclinoid, right? And then they further went on to subdivide their supraclinoid segment into ophthalmic, communicating, and choroidal. It's a simple, it's elegant, it's better than Fisher. but it predates the era of dural rings and clinoid discussions, but it somewhat continues to be in use. This picture puts forward the Fisher classification, the Gable classification, and the Berthelier classification, which is what we use as standard right now, Berthelier, and which we will describe in detail. Now, it's important to note that somewhere in the middle through all of this, there were other classifications. You had Zell et al. They would have done one based on the detailed microsurgical dissections in terms of the relationship between the carotid artery, the lacerum, and the proximal cavernous sinus, where they basically just excluded or suggested that you don't have a distinct room for the lacerum segments. You also had Laswanis et al. Doing one based on embryological framework. It was brilliant conceptually, but in terms of the usefulness for surgery and aneurysmal surgery, it really didn't help us too much. So moving on to the Berthelier's classification devised in 1996, which divides the ICA into 7 segments. And this provides a beautiful anatomical roadmap. It's widely used, like I would have said, in neurosurgery and radiology, making it a standard reference today in terms of clinical practice. So you have C1, cervical segment, C2 or petrous, C3 or lacerum segment, C4 cavernous segment, C5 or clinoid segment, C6 ophthalmic, and C7 communicating. And we're going to go through each of these now because it is important that we're able to grasp the anatomy of the internal carotid artery. So this picture is on every slide coming up so that we could follow along. I mean, a picture tells 1,000 words. So C1 or the cervical segment. So remember, common carotid artery branches into ECA and ICA. So for your C1 segment, it begins in the neck at the carotid bifurcation. And in essence, from the carotid bifurcation to the carotid foramen at the skull base. It's usually encircled with postganglionic sympathetic nerves. The ICA travels in a carotid sheath, as we would have mentioned before, and it ends specifically when it enters again the carotid canal at the petrous bone. Now, what is very important to note is that there are no branches of C1 or the cervical segment. C2 or the petrous segment. So we've come up the road and we've gone to the carotid canal, C1, C2. We're now moving from the carotid foramen to the posterior edge, this dotted white line that you can see, to the posterior edge of the foramen lacerum. And it ends at the posterior edge of the foramen lacerum, inferior medial to the edge of the gastrin ganglion in Meckel's cave. It's important to note that C2 is still surrounded by postganglionic sympathetic nerves, and there are 3 intraosseous and segments and 3 intraosseous branches of C2, or the petrous segment. So we've established C1 and we've come across to C2. Now, the intraosseous segments of the ICA. So in essence, remember we're right here, C2, you have a vertical segment, you have a genou, and you have a horizontal segment. So the vertical segment occurs as the ICA ascends, and then it bends. It's just about 10 millimeters in length. And then it bends and forms a little bit of a posterior loop that you can see there, which is anterior to the cochlea. It bends anterior medially, becoming the horizontal segment, which is almost double the length of the vertical segment, 20 millimeters. And at that point, it exits at the edge of the foramen lacerum. And at that point, it is deep and medial to the greater and lesser superficial petrosal nerves and anterior to the tympanic membrane. So we've covered C1 and C2, and we're moving along to C3. Sorry, before we move along to C3, importantly, the branches. So intraosseous branches of the ICA. So really, C2, same thing, comes up, C1, C2, and you have the caroticotympanic artery, which is really an embryonic hyoid artery remnant, and it rises near the genou that you spoke about. Remember, we spoke about horizontal genou, vertical, horizontal genou, and vertical, right? So it passes superiorly to supply the middle and inner ear. You can also have the Vidian artery, which travels through the Vidian canal and foramen lacerum, that can originate from this horizontal petrous segment of the ICA. And lastly, as a branch of C2 or the petrous segment, we have periosteal arterial branches, which are persistent arteries of the petrosal or the intraosseous segment. And these two that tend to originate from C2 are the persistent stapedial artery and the otic artery. So we're moving along and we've gotten to C3 now. Now, importantly, the ICA passes over, but not through the foramen lacerum, forming a lateral loop. And it ascends in the canalicular portion of the foramen lacerum to the juxtacellular position, piercing the dura as it passes the petrolingual ligament to become the cavernous sinus, right? And usually it's not too visible angiographically, but that is the C3 segment. Moving from the C3 segments that we would have just said, it now exits from the IC at the it extends from the IC at the exit from the carotid canal and terminates into the subarachnoid space adjacent to the anterior clinoid. Now, it is still covered by a vascular membrane lining the sinus. So at this point, C4 in essence travels in the cavernous sinus and is covered by the trigeminal ganglion. Cranial nerve 6 lies inferior laterally. Cranial nerve 3, 4, and trigeminal 1 and 2 are lateral within the lateral dural wall. It then ends at the proximal dural ring, right? So that is where C4 ends. It ends at the proximal dural ring. And the intracavernous branches of ICA, which become very important, are the meningohypophyseal trunk, the inferior lateral trunk, and the medial trunk. And the meningohypophyseal trunk is the largest and most proximal, and we would go into the different branches of the meningohypophyseal, inferior lateral trunk, and medial trunk. So I hope that we're all following along in terms of where we are from C1, 2, 3, and 4. So we're still at the cavernous sinus, the intracavernous ICA, where in essence, we've gone up, right? Part 1 is posterior vertically, and then we have a little bit of posterior bending. It goes horizontally, and then it bends anteriorly, and boom, we get up to the anterior clinoid process. And this is the course of C4. Now, branches of the cavernous segments of the internal carotid artery. So we would have spoken about the fact that there's the meningohypophyseal trunk, which is the posterior trunk, which we could see here. I hope you're all seeing the cursor or the laser, right? In essence, this meningohypophyseal trunk branches into the tentorial artery of Bernasconi and Casinari. It branches into your inferior hypophyseal artery, and this is particularly important because the clinical correlate would be postpartum occlusion causing pituitary infarcts or Sheehan's necrosis. And you also have the dorsal meningeal artery coming from the meningohypophyseal trunk. And then you have the inferior lateral trunk, which is this bit right here, or the artery of the inferior cavernous sinus, which then travels to the inferior lateral cavernous sinus wall, the tentorium, the foramen ovale and spinosum to supply cranial nerves 3, 4, 5, and the gasseron ganglia. And then lastly, the third one would have been the medial trunk, right? And this medial trunk, or the capsular arteries, is what we know as McConnell's capsular arteries that supply the anterior and the inferior pituitary gland. It tends actually to only be present in only in 28% of the population, and the most distal branch is from C3 and C2. So this covers the branches of the trunks of the cavernous segments of the internal carotid artery. C5 and C6. So we've gotten it clear. We've come up from ICA, C1, right? Carotid canal. We've come across to C2. We've exited foramen lacerum. We've come under petrolingual. We've gone through our cavernous, and we're now at C5, or the clinoid segment. And this lies between the proximal and distal dural rings. So C5 ends at the distal dural ring, which completely encircles the IC. So in essence, after C5, it becomes completely intradural. Then we have C6. C6 is the ophthalmic segment. It's from the distal dural ring, just below the posterior communicating artery. And the branches of this is the ophthalmic artery and the superior hypophyseal artery. So the ophthalmic artery, the origin from the ICA, is distal to the cavernous sinus in about 89% of persons, right? Even though the ophthalmic artery can also be absent in about 3% of the population. So it's important to know that the ophthalmic artery passes through the optic canal into the orbits. It has a very short intracranial course, just about 1 to 2 millimeters. And I would have mentioned the other branch of the ophthalmic segment is the superior hypophyseal artery. And these are several small branches, and they course beneath the optic nerve to supply the pituitary and the optic nerve and chiasm. Now, what becomes even more vital with the superior hypophyseal is that the arteries of that anastomose with the arteries of the contralateral side, as well as the inferior hypophyseal arteries, to form the hypophyseal portal system. And the last segment of the internal carotid artery is C7, or the communicating segment, which is here. Remember, C6 just ended proximal to the posterior communicating. So C7, in essence, begins exactly there. It begins just proximal to posterior communicating artery, travels between cranial nerve 2 and 3, terminates just below the anterior perforated substance, where it then bifurcates into the anterior and middle cerebral artery. And the branches are, naturally, as we see it here, the posterior communicating and anterior choroidal artery. So in terms of the internal carotid artery segments, we've covered it as per the Bethelius classification, all 7 segments. And though on the left you see artist description, you see a description in terms of the vessels and angiography of mimicking how C1, C2, C3, 4, 5, 6 goes, and that they end in the anterior and the middle cerebral artery. Another tidbit to note in terms of the branches, I've just put this here as a summary slide, but a nice way of remembering it is that except for the terminal segment C7, the odd numbered segments have no branches. So the even numbered segments, C2, 4, and 6, are usually the ones that have branches, even though sometimes they can be inconstant, right? But importantly, we've gone through the cortical tympanic branch, the Vidian, we've gone through the superior and inferior hypophyseal arteries, and now we're going to shed light on the cerebral part, which would be the ophthalmic, the anterior choroidal, posterior communicating artery, and terminal branches are our next big guys, the anterior cerebral artery and the middle cerebral artery. So the ophthalmic artery arises as the internal internal carotid artery emerges from the cavernous sinus. Like I said before, it enters the orbit through the optic canal below and lateral to the optic nerve, supplying the eye, orbital structures, and some finer branches of it actually supply the frontal area of the scalp, the ethmoid and frontal sinuses, and the dorsum of the nose. The anterior choroidal artery, it arises from the posterior medial surface of the ICA, right? And just to refresh our memories, right here. So anterior choroidal artery arises from the posterior medial surface of the ICA, about 2 to 4 millimeters distal to PCOM's origin. It's a very small branch, but it passes posteriorly close to the optic tract, enters the inferior horn of the lateral ventricle and ends in the choroid plexus. It anastomoses with the lateral posterior choroidal arteries, and it has 2 segments, cisternal and intraventricular. It gives off numerous branches to supply the lateral geniculate body, the optic tract, as well as the internal capsule. The posterior communicating artery. No, it tends to be smaller than your posterior cerebral and your internal carotids, of course. It arises from the posterior aspect of the intradural internal carotid artery, coursing above cranial nerve 3 to join with the horizontal PCA. Because remember, all of this is, in essence, we're still forming our circle at the end of the day. Now, posterior communicating artery. You have 7 perforators being evenly distributed to supply the posterior hypothalamus, the anterior thalamus, the subthalamic nucleus, as well as the posterior limb of the internal capsule. The largest perforator is the anterior thalamo-perforating artery, and that terminates between the mammillary bodies and the optic tracts. Now, we have variants, and we will touch on variants in most of these things as well, but the PCOM variants are observed in about 50% of cases, and they can range from absent or hypoplastic in up to 30% of cases, or fetal origin in up to 20% of cases. Now, importantly, and we'll do this when we do aneurysms, but aneurysms usually arise from the posterior wall of the carotid artery, just distal to PCOM's origin, and those would point posteriorly towards cranial nerve 3. The carotid siphon, I included it because, you know, it's something, it's an anatomical structure, but that is really more a radiological landmark. So the boundaries are not well anatomically defined, but it bears particular importance because it's a tortuous vessel segment with sharp bends through which blood enters the anterior cerebral circulation. I mean, it's a U or a S-shaped part of the IC that varies with age, and it begins at the posterior bend of the cavernous part of the IC and ends at the cerebral part. I mean, when you really look at it and you think about it, and the star here really points because there's a lot of orange signs here, right there, in that sharp bend, is your carotid siphon. So when you think of the curves and the shapes, it really is a vascular marvel, you know, but it's thought to aid in pressure regulation and flow dynamics to ensure laminar flow for efficient oxygen and nutrient supply. But it's also very common said for aneurysms and atherosclerosis. And so it becomes very crucial in our understanding of identifying and treating cerebrovascular diseases. In fact, because of the anatomic peculiarities of this region where the carotid siphon is, about up to 1/3 of all intracranial aneurysms are located at this site. And in fact, there was a study that was done recently on the title, The Influence of the Carotid Siphon Anatomy on Brain Aneurysm Presentation in 2018. And what they found was that there was a significant independent direct relation of greater numbers of aneurysm located distal to the carotid siphon, large aneurysms, and a greater risk of rupture. And that was also linked to the fact that it could be associated with the hemodynamic interactions of blood flow and the curvature of the carotid siphon. I did say that we will touch on variant anatomy just for us to be aware of. So in terms of variant anatomy, we can have an aberrant ICA, which really, it represents a collateral pathway resulting from involution of the normal cervical portion, which was the first embryonic segment of the internal carotid artery. You can also have a congenital absence of your ICA. It is rare, it's less than 0.01% of the population, but this group encompasses agenesis, aplasia, and hyperplasia. You can also find a retropharyngeal course of your ICA, and it tends to be termed kissing carotids, referring to the tortuous and elongated carotid arteries, which would then touch in the midline. You can have persistent carotid vertebro-basilar anastomosis, and you can have a lateralized internal carotid artery, and a lateralized internal carotid artery actually is an anatomical variant of the petrous portion of the ICA, where in essence, particularly on CT, what you're going to see is a more posterior lateral entrance to the skull base and protrusion. So we've wrapped up the ICA, and we're going to continue with the anterior cerebral artery, which would have said the ICA eventually went to form the anterior cerebral artery and the middle cerebral artery. So it arises from the ICA lateral to the optic chiasm, and it primarily supplies blood to the medial surface of the cerebral hemisphere, except for the medial occipital lobes. Its course, after it arises from the anterior clinoid portion of the ICA, and then it courses anterior medially over the superior surface of the optic chiasm towards the longitudinal fissure. After it gets there, it forms an anastomosis with the contralateral AC, and that anastomosis is called the anterior communicating artery. Now, in terms of classification, it can be divided into the pre-communicating and post-communicating segments based on the proximal and distal location to the anterior communicating artery. So the anterior communicating artery is very crucial to our understanding of the anatomy of the anterior cerebral artery. And this was really based on Rotan's classification in essence. There have been other classifications described, such as this one, A1 to A5. So walk with me again. We have our ICA. Our PCOM comes on for our anterior choroidal, and we said our terminal was in essence your MCA and your ACA. And what did I just say? The anterior communicating artery is what helps to distinguish our pre and our post communicating segments in essence. So from A1 is the ACA, is going to originate from the origin to ACOM, and then from ACOM, right, to a branch point, which is actually your colossal marginal artery or your CMA, that is A2, or your post-communicating segment. So A1, pre-communicating, we see ACOM. A2, your post-communicating. And then A3 is your pre-colossal. And what happens here is that we're now moving. A3 starts from our colossal marginal artery. It goes around the genu of the corpus callosum to the superior surface, about 3 centimeters posterior to the genu. That is A3, or your pre-colossal. And then now we're on top of our colossal. That's your supracolossal. And it ends as A5, your post-colossal. This is just another representation of exactly what we just said. A1, pre-communicating. ACOM splits it in essence. We have post-communicating, colossal marginal coming up. And from colossal marginal to about 3 centimeters, remember, past the genu is A3. Then we have our supracolossal and then our post-colossal. The way we want to remember it, though, is ACA segments really A1 to 3, which is yet another classification in a sense, where you have horizontal or pre-communicating, vertical or post-communicating, A3 distal ACA, and cortical branches. Easy squeezy makes the most sense. So A1, pre-communicating segments, in essence, you have 12 perforating arteries coming from this, and these are called the medial lenticulostriate arteries coming from A1. And they course posterior superiorly to the anterior perforated substance to supply the optic nerve, the optic chiasm, the anterior hypothalamus, the septum pellucidum, and the anterior commission. And remember, the anterior communicating connects our right and left ACAs, usually at the level of A1 to A2 junction. Now, this table summarizes nicely for us A2 and the features, recurrent, and the branches of A2, I should say. The recurrent artery of Hübner, orbitofrontal artery, frontopolar artery, and anterior inferior frontal artery. And in fact, we can see it here. So let's just always try to put the speech and the words and the pictures together. So the internal parotid, we see this, the anterior choroidal, the medial orbitofrontal, right? The frontopolar that we speak about, and the anterior internal frontal. So these are the branches, in essence, of A2. And the recurrent artery of Hübner is very important, and it would get a little talk by itself. But it arises, like we said, distal to the ACOM and courses back, and that's why it gets the name recurrent artery of Hübner. And it enters the anterior perforating substance and supplies a lot of places. Vascular territories would be the head of the chordates, the anterior limb of the internal capsule, globus pallidus, putamen, and the inferior frontal lobe. A3, right? So A3 now, you have your colossal marginal, your pericolossals, your middle and posterior internal frontal, paracentral, superior and inferior parietal artery. And remember, A3 is your distal segment. It is distal to your pericolossal, and your colossal marginal. So it is distal. It is everything distal to that. So this is A3 really supplies your parietal cortex, your frontal cortex, as well as your cingulate gyrus and paracentral lobes. And I did say that we're going to touch on recurrent artery of Hübner because it becomes very crucial. The origin is from the ACA, as we say, at the A1 to A2 junction, or within a few millimeters of the proximal A2 segment. It is known as the medial striate artery. If it doesn't originate there, the remainder originates from the A1 segment. And as I would have mentioned previously, it curves back sharply on itself, parallel the A1, and therefore is at risk in surgery during anterior communicating artery aneurysmal clipping. And this is why it's especially important for us always to be aware. And this is some pictures showing you A1 and then your recurrent artery of Hübner. And we can see it here. Remember we said that it can be at risk in ACOM aneurysmal surgery. So this is ACOM joining left and right ACA. This is your right recurrent artery and the left recurrent artery of Hübner. I mean, you have to think of it in a 3D spatial manner, right? But clinical manifestations of occlusion include, if it's unilateral, it will be weakness of the contralateral arm and face, dysarthria, and hemicardia. If it's bilateral, the patient could present with akinetic mutism. So anterior cerebral artery. We've seen where it originates, and we've seen all the many different branches. And it's a lot to process. But the major branches of the anterior cerebral artery are the orbitofrontal, frontopolar, anterior, posterior, and middle internal frontal, which we would have described already, as well as your inferior and superior parietal branches. So just bear that in mind and the regions when you see these pictures of where the ACA is going to supply. I've included these two tables for the sake of it provides a lovely summary in terms of the different segments of ACA, the boundaries, the branches, the regions supplied, as well as some important variants. All things that we've gone through already, it's just in tabular form. So to round up on anterior cerebral artery, we'll just touch on the variants that you can see. You can see ACA fenestration, which you see up to 4% of A1 segments. Azygous ACA, the territories tend to be supplied by a single A2 trunk. You can have ACA trifurcation, where you have three A2 segments, in fact, and the incidence is as high as 7.5%. You can have bihemispheric ACAs, where you end up with a hypoplastic A2 segment, right? And a contralateral, because one side is hypoplastic, the other side then becomes dominant in essence to supply. You can have A1 segment absent, so hypoplasia, the duplication of A1, 2 or 3 ACOM arteries, asymmetry of A1 segments. You can have a persistent primitive olfactory artery, and you can have intraoptic ACA. And what that is where the ACA travels inferior or through the optic nerve. So I've just included a few images to show you some of these variants. So this one is a CT of the brain where we could see bilateral fenestration of the A1 segments, right here and here, and you see it zoomed up here, left and right, of the anterior cerebral artery. And that's incidental bilateral fenestration that was found of the A1 segments. This one is an MRI, which shows a beautiful example of a common variant of the circle of Willis where the right A1 is tiny. In essence, you could almost not see it, and the A2 is supplied by a large ACOM instead. And then this was showing the ACA triplication, which I just thought was pretty cool. The MRA showed where you have your two A2 segments identified by your red arteries, not arteries, your red arrows, sorry, and then a smaller branch right here that's originating from your ACOM, right? And that's a frontopolar branch. So instead, you could actually think that the patient has two ACOMs when in fact it's truly one. The patient just has three, and you can see it better here. 1, 2, just above the red, and then 3 of the ACA. So the anterior communicating artery, which we've been yapping about as well, it arises from the anterior cerebral artery. It's about 4 millimeters in length. It demarcates the junction between the A1 and A2 segments of the anterior cerebral. And importantly, it acts as an anastomosis between the left and right anterior cerebral circulation. Via its anterior medial central branches, it supplies part of the optic chiasm, lamina terminalis, frontal cortex. Now, one of the frequent variations you see of the anterior communicating artery is duplication of that vessel. Now, another thing that is quite important with the anterior communicating artery is that because it's located in the cistern of the lamina terminalis, in the event of a ruptured aneurysm, of an ACOM aneurysm, it can cause an intraventricular hemorrhage into the third ventricle through the membrane of the lamina terminalis. And the anterior communicating artery is quite crucial for us to know because it is a recognized site of aneurysm predilection, accounting for up to nearly 25% of all cerebral aneurysms in several large studies. In fact, some literature has quoted it as up to 40% of intracranial aneurysms. So we've been doing a lot, but this picture is just putting us back to base in terms of where we are. We've gone through the internal carotid. We've gone through the anterior communicating artery. We've gone through the anterior cerebral. We've spoken about the ophthalmic arteries and the anterior choroidal as it branches. And to round up today's discussion and presentation, we'll talk about the middle cerebral artery. So the MCA, it is the largest and most complexly distributed of the cerebral vessels. It originates from the bifurcation of the ICA, just lateral to the optic chiasm at the medial end of the sylvian fissure, and passes laterally from there along the ventral surface of the frontal lobe. Then it bumps into the sylvian fissure between the temporal lobe and the insular cortex. Now, within that region, it then typically bifurcates or trifurcates in some cases, giving rise to 2 or 3 principal trunks. And what that does, it then supplies a lot of critical cerebral structures along its sinus course. It has a relevant consistent route in that they found variations in about up to 4% of patients, but it's not been determined to be of clinical significance. So in essence, after it bifurcates and trifurcates into these principal trunks, it then arborizes and spreads over most of the lateral surface of the cerebral hemispheres into the cortical territories, the insular cortex, the ocular surface, the parietal territories, including the inferior and medial frontal gyri, and thus we then understand why MC is the most common site of stroke, and that large territory MC strokes often carry a very poor prognosis. So again, classification. For anatomical purposes, it's been segmented into 4. M1, 2, 3, 4. M1, sphenoidal or horizontal segments. M2, insular segments. M3, opercular segments. And M4, cortical segments. Again, M1, we follow it, M2, M3, and then it bumps down to M4, right? So M1, it is proximal to the bifurcation or trifurcation, and it extends horizontally, as we could see, beneath the anterior perforated substance. And then M2 extends from the bifurcation, right there, to the genou, which courses and heads posterior superiorly. Where did I say it went? Into the sylvian fissure. And then M3 is when it bumps out of the sylvian fissure and is a continuation in essence of M2. And then M4 is your cortical segments, right? So I hope that this puts it into perspective in terms of the segments of the middle cerebral artery. So M1, 2, 3, 4. M1, we have lateral lenticulostriate arteries as branches, and these are generally perforators, really, about 2 to 15 in number, and they cover vast vascular territory as outlined in the table. You have your anterior temporal and your temporal polar arteries, and these supply your anterior polar of your superior, middle, and inferior temporal gyri. And then you have your uncal artery, which supplies the uncus and underlying white material. And then your M2, right? And let's just refresh your memories as to where M2 is. Remember, M2 extends from the bifurcation to the genou and then courses down into the sylvian fissure, right? And then ends off as M3 and M4. So M2 has a superior trunk and an inferior trunk. Your superior trunk, orbitofrontal branch, prefrontal branch, precentral branch, central branch, right? And in essence, these together, it's outlined in the table, what they supply, right? In essence, they supply a lot of your gyri as well as your superior parietal lobe. And then the inferior trunk has branches to the posterior parietal region, an angular branch, which helps to supply your temporal gyrus. And this becomes especially important because it is the largest cortical branch of the middle cerebral artery. You have your temporal occipital branch, your posterior temporal branch. One of the things to remember is if you occlude the posterior temporal branch, your clinical correlate would be you have wernicke's aphasia and hemianopsia. And your middle temporal branch, as well as another branch of M2. So your middle cerebral artery, just as I would have shown you what your anterior cerebral supplies, your middle cerebral artery, you have major terminal branches, and these are your orbital frontal, or this one, right? Lateral frontabasal, your prefrontal, your precentral, your central, artery to the central sulcus, your postcentral sulcus as well, your posterior parietal, your middle and posterior temporal branches. So the branches vary a lot, but these are the 10 most common branches in terms of terminal branches of your middle cerebral artery. Now, what this diagram intends to do is to just put it together a little bit in terms of the arrangement of the middle cerebral artery and the anterior cerebral artery that we would have spoken about. Remember, ICA, A1, A2. It doesn't show all, of course. Your recurrent tubular artery, and then M1. M1, then 2 slips up into sylvian fissure and comes down M3 and ends off as M4. And likewise, how I've included a table, sorry, for your anterior cerebral segments. There's one as well for your middle cerebral artery segments, and their supply in terms of the branches, the area supplied, and the anatomical path. And it's nothing that we've not spoken about tonight. It's just for the sake of a summary. So the variant anatomy of the middle cerebral artery. So a little bit less in this case. MCA duplication has a reported incidence of about average 1.5%. I mean, it ranges up to 3%. You can have an accessory middle cerebral artery. You can have MCA fenestration as well. Remember, I outlined the ACA fenestration to you. You can have MCA fenestration as well, but it's rare. He has a reported incidence of 1%. And you can have early branching of your MCA with bifurcation or trifurcation occurring within 1 centimeter of its origin. And just for the sake of diagrams, in this case, duplication, we've seen two middle cerebral arteries originating from the distal end of the internal carotid. You can see it better here. You see one on the left, but you have two on the right. And then you can also have an accessory middle cerebral artery on the left, as outlined here, arising from the A1 segment of the left AC. So that's just a little bit about variants of the MCA. So this picture is to remind us of what we've done and what else is to come. So we've done anterior cerebral, we've done middle cerebral, we've spoken about the internal carotid, we've touched on the posterior communicating, which covers the anterior circulation of the brain. And then next week's presentation, we would cover the remainder, all of this, the complete Earth circle of Willis. Thank you for your time and your attention. And these are my references.